So, welcome to today's podcast. In this episode, we're exploring wound care within hospice and palliative care settings. Wound care is something many health professionals are regularly involved in, yet it can feel really complex, particularly when caring for people approaching the end of life. Today, we'll look at why skin integrity is often compromised, the role of the multidisciplinary team in wound care, and importantly, how wound dressings are used to support comfort, dignity, and quality of life. I'm joined by Suzie, practice educator with hospice education and a registered nurse with extensive experience in palliative and end-of-life care.
Lovely to be here. Great to have this opportunity to share some knowledge with you.
Brilliant. Thank you, Susan. It's fantastic to have you here.
Thank you.
So, can you actually describe your experience managing wounds in palliative care settings and with palliative care patients?
Sure. So I've managed various wounds in palliative patients. The main ones being, I'd say, are pressure ulcers, malignant fungating wounds, or surgical wounds. The approach is slightly different in the sense that you prioritize comfort and dignity rather than healing the wound.
Yeah.
And you use evidence-based dressings and techniques to reduce the pain, odour, or exudate. So we also work closely with the multidisciplinary team to align wound care with the patient's overall goals of care.
All right, lovely. And actually, what multidisciplinary teams would be involved in this?
Various teams. So we've occupational therapy, physiotherapy, RNs. So different RNs. We've got community or inpatient based, GPs, medical team, carers are an integral part of care. And then you've got specialist nurses. So if you need specialist advice, you've got the tissue viability nursing team. And then also obviously the clinical nurse specialists who might be managing that patient in the community.
Lovely, thank you, Susie. So what types of wounds are actually most common in palliative care and how would you approach them?
So really, I'd say pressure ulcers are common due to multiple risk factors such as poor mobility, nutrition, hydration, incontinence, for example. And then you've got malignant wounds as well alongside that. So for the pressure ulcers, I'd focus on prevention through repositioning and pressure relieving equipment, such as mattresses, cushions, etc. And then for the malignant wounds, I want to manage the symptoms. So for example, odour, that's quite debilitating for someone. And managing that is massively beneficial for mental health as well. And then you've got exudate. So you're using an absorbent dressing. In terms of the odour, we want to use a charcoal dressing, which masks that odour for them. And doing all this, making sure there's minimal discomfort during the dressing changes.
Right. So you've spoken about a couple of dressings there. So how do you decide on the most appropriate dressing for a wound in a patient receiving end-of-life care?
Okay, so there's various factors you want to consider. The wound type, the level of exudate is a huge one actually. Infection risk and patient comfort. So patient comfort is the most important part of it. For example, I might choose a hydrocolloid dressing for shallow wounds and an alternate dressing for heavy exudate. So my priority actually is symptom control rather than healing, and respecting the patient's wishes and overall care plan.
Absolutely. And I really understand that patient comfort and dignity is a real priority at end of life.
Definitely.
So, how do you assess and manage pain associated with wounds in your palliative patients?
Okay, so I use actually a pain assessment tool, like a numeric rating scale or observational cues for non-verbal patients.
Yeah.
Um, so I use Socrates or Socrates, which, if you break it down, you're looking at where the pain is, so site, and then onset, so when did it start? The character of the pain, is it a sharp pain? Is it a dull ache? Radiation, does it move? Does the pain go up and down your legs, down your arms? Have you got any associated symptoms? So nausea, vomiting, fever, palpitations, etc. And then the time course. So how's it progressed? Has it got worse over time? Is it getting slightly better over time? And is there any exacerbating or / soothing factors? So does anything make it feel better? Is there anything that makes it a lot worse? So you're kind of looking, and it's a great tool just to kind of have a full assessment of that pain. So pain management obviously includes when you're going to do a dressing, you want, it includes pre-medication before the dressing changes, so that patient has the pain not resolved but lessened throughout that experience. So pain management includes pre-medication before dressing changes, using atraumatic dressings which minimize pain, minimize skin stripping and tissue damage, and also collaborating with the medical team or other teams for systemic analgesia. So comfort is always the primary goal.
So you have spoken a lot there about comfort and about pain strategies. Is there anything else that you would consider to use during the dressing changes, or anything else you would need to consider there?
Yeah, so we're looking for a calm environment, talking through what you're doing with the patient or the patient's family, explaining each step, and using gentle techniques. I'd pre-medicate if needed. You can warm up solutions, select dressings that require fewer changes. I also involve the patient in decision making to reduce that anxiety. So comfort, like I say, is always the primary goal.
Brilliant. So how would you balance wound healing goals with that comfort and dignity that you speak about so passionately within the palliative care setting?
Okay, so in palliative care, the focus shifts from healing, as I've said before, to symptom management. I prioritise reducing pain, odour and leakage and maintaining dignity by ensuring privacy and involving patients in choices. Healing is secondary to quality of life.
Yeah, I think that's you know, everything you've spoken about, that really does come across there. And I take it it's about involving patients and families in those wound care decisions.
Absolutely. So I like to provide clear, compassionate explanations about the wound and the care options, emphasising comfort, as I keep saying.
Yeah, no, it's so important.
Obviously respecting cultural and personal preferences, and encourage like shared decision making, ensuring families feel supported and informed.
Absolutely. So it's also about communicating with the multidisciplinary team, I would imagine, within that wound care setting in your palliative care setting.
Yeah, no, absolutely. So we have daily multidisciplinary meetings here at the hospice. but we don't get to see everyone face to face. We don't get to, communicate really with other professionals in other organisations. So the best thing I would say is documenting wound assessments accurately, sharing updates during those team meetings. So collaborating with the doctors, dietitians, physios, to address actually underlying issues like your nutrition, mobility. So really it's ensuring a holistic care approach.
So do you ever have any situations where patients or families actually refuse that wound care intervention?
Yes, absolutely. So I listen to the patients' and families' concerns. You're able to provide education and give them the benefits, what are the risks, and then respect their autonomy, respect their decision. Because if they still refuse, again, we go back, we document everything, we document that decision and focus on alternative comfort measures for them, and making sure you're involving the team and there for support, etc.
Yeah. And then I would imagine that infection control is huge within wound care. What steps do you take to prevent infection for patients with compromised immunity?
So in the community, which is my background, we use the aseptic non-touch technique. Which they would use in an inpatient setting as well. It's just a different aseptic technique. You're able to be a bit more aseptic in an inpatient setting. So, so I'd be selecting antimicrobial dressings where appropriate. We're monitoring every time we see that wound. We're monitoring for signs of infection. As I said about education, so educating caregivers on hygiene and escalating concerns promptly to a GP or a medical team, etc., if you're concerned about the wound or it's deteriorating.
Right. So that's when you would escalate a wound-related concern to a specialist.
100%. So even if it's just to get a bit of advice over the phone, or they will come out and see it occasionally. So yeah, definitely.
Thanks, Suzie. So as we close, what key message would you like listeners to take away from today's podcast?
I would probably say wound care in hospice settings is about comfort, dignity, and compassionate observation. Dressings are not just clinical tools, they are part of how we care for people at the end of life.
Oh, thank you so much, Suzie. And thank you for our listeners for taking the time to reflect on wound care practice in palliative and end-of-life care settings.